First of all, I'm going to present the 4 discussants and thank them for having agreed to participate in the discussion of these cases. Susanna Price and Malcolm Bell have been introduced before, and I'll have the pleasure to introduce you Dominique Angiolillo and Frederick Moore. Dominique is an interventional cardiologist, professor of medicine at Jacksonville University in Florida, and he has a very strong background on thrombosis research, as you all know, and platelet function and antiplatelet treatment. And Professor Moore is a professor of cardiac surgery at Leipzig University and medical director of the Heart Hospital, the Heart Centrum in Leipzig. And he has been chair of the German Society of Cardiac Surgery, and now is chairing the European Society of Cardiothoracic Surgery. So thank you very much again to all of you. And we have 2 cases, one of a chronic patient, another more acute condition. And the cases will be presented by Dr. Maria Terricabras, the first one from Hospital University Valdebrón in Barcelona, the second one by Marta Alonso from the Hospital Clínic Universitario of Salamanca. I have to say that the 2 cases have been selected by the scientific committee of the symposium after a tough discussion and grading of more than 40 cases that were selected to be presented here. So first of all, congratulations to both of you for having your cases been accepted. And you can start, Maria, with the first case.
Okay, I'm going to present the first case this afternoon. And as you will see, it represents a frequent clinical scenario in our daily practice, but despite this, I hope it will generate a lively discussion. So the first time we saw this patient, he was 71 years old, and he had a 6-month history of typical chest pain, which was stable, but class 3. And he also had an ischemia imaging test, which was positive. He was a former smoker, he had diabetes, hypertension, dyslipidemia, an OSA under CPAP therapy, and he also had peripheral artery disease, symptomatic with claudication at only 200 meters, and a carotid artery disease that had recently been diagnosed. So at that moment, he was under treatment with ASA, 100 milligrams daily, bisoprolol, 500 milligrams daily, enalapril, 20 milligrams daily, simvastatin, 20 milligrams daily, and metformin twice a day. His physical examination at the moment of the admission was a heart rate of 52. He had a good control of his hypertension. He had no heart murmurs, no signs of heart failure, and he had both carotid and femoral systolic murmurs, and also diminished peripheral pulses. Here we can see the blood work, and he had good control of his diabetes, but a mild renal impairment with a creatinine of 1.14. His cholesterol level was 174, and the LDL cholesterol was 89. Here we can see the ECG. He was in sinus rhythm with a narrow QRS. He also had a left anterior hemiplegic, and we can see here negative T waves in inferior lips and a minor ST depression in lateral leads. The chest X-ray, which was normal. And here comes the first question. Do you think that this patient was receiving optimal medical therapy, or you would change something? Maybe we could add a second antiplatelet, increase beta blockers dose, withdraw enalapril, add a second anti-anginal drug, or add a second anti-anginal drug and also change simvastatin to a more potent statin.
So we don't have any of these devices to electronic voting, but the more traditional ones are still valid. So Please raise your hands. Who of you would add a second antiplatelet agent to this patient? Increase beta blocker dose. Withdraw enalapril. Adding a second anti-anginal drug. And the same plus changing to a more potent statin. That's the majority. Any comment from?
That's what we actually did. And as I've said before, he had a positive aspect. He had 3.3 minutes, reaching 5.1 meds, 98% of maximum heart rate. An ST depression appeared the first moment, and the test was limited by angina. And in the images, we saw non-transmural inferolateral necrosis, moderate inferolateral ischemia, and mild anterior ischemia. We also had the gated aspect with 38% of ejection fraction. And here we can see the echocardiography with a non-dilated ALB, with mild hypertrophy, inferior hypokinesis, and a moderately reduced ejection fraction, like the gated aspect. So what should be the next step? Maybe we could maintain the same treatment and just follow up, increase anti-anginal therapy and repeat the SPECT, perform a coronary CT scan, perform a coronary angiography, or maybe perform a cardiac MRI to identify viability.
So who would opt for the first one? Number 2. Number 3, CT scan. Number 4, invasive angiography. Number 5.
Nobody.
Do you have any comment, the panelists, regarding the usefulness of this test?
I think it's obvious that there is a significant coronary artery disease, and we have to check. We have to check the coronary angiograms, which is best still done by coronary angiography. Since he has the posterior wall is kind of non-perfused, we have to define whether there's this hibernating myocardium or not, and we could use the MRI to see whether we can, whether it makes sense to revascularize that section as well.
So I could make the argument you had a patient with diabetes, multiple cardiovascular risk factors, with clear angina, class 3, and documented vascular disease. And one can say, why didn't the patient just go to get a heart cath without the nuke? At this point, you have most of the information, so I think I personally would have sent the patient directly for a heart cath.
Okay.
We agree. We performed the coronary angiography. But if we remember, this patient was diabetic and he had a mild renal impairment. So before the angiography, would you take any special measures? Maybe no. Maybe we would change metformin to insulin. We could change metformin to insulin and also start hydration with sodium chloride for 24 hours. The same, but instead of sodium chloride with sodium bicarbonate. Or we could do everything, change metformin to insulin, give hydration with sodium bicarbonate, and also give oral N-acetylcysteine.
So this one is not so simple. Who would maintain the same treatment, metformin, and no special measures before coronary angiography? Please raise your hands. No one. Who would change to insulin? Number 2. Number 3, hydration with saline. Number 4, bicarbonate. And number 5, acetylcysteine. Any comment from the panelists regarding the optimal prevention of contrast-induced nephropathy in this patient if needed?
Unless I'm getting my European units mixed up, the creatinine was normal though, wasn't it? Or not?
The glomerular filtration rate was 55. It was mildly reduced.
Yeah, so so stage 3 chronic kidney disease, yeah. But so I can tell you that at our institution, this patient would be managed as an outpatient, so we would not bring this patient in 24 hours before for hydration. We would start hydration just with sodium chloride prior to the cath. We'd continue that afterwards, and we would minimize contrast administration and often do these biplane. It's obviously an important concern here. And we would generally just hold the metformin and make sure that the patient does not develop renal failure, and so we wouldn't be switching to insulin. But as an outpatient, this would be a fairly straightforward type of case. But as I said, minimizing contrast administration.
And we probably would have the same protocol. The patient would come as an outpatient, just stop the metformin, have them come in early in the morning, hydrate for a couple of hours, and minimize contrast. The other thing that we like to do in patients with chronic kidney disease is do their cases in the morning, because their hydration status is always best in the early hours.
Again, just one other thing. I mentioned biplane angiography, and I don't know how many biplane units there are in Spain, but for a case where we're really trying to minimize contrast, you can often do this with maybe 15 or 20 cc's of contrast with very good pictures in the majority of patients.
Wouldn't it make sense to clear the peripheral arteries as well? His PBI was extremely low, 36 and 42. I think he has severe arteriosclerotic disease, either at the iliac level or the femoral level. So it would be nice to find out at the same procedure what needs to be done over there.
If there is any comment or a question from the audience, please feel free to ask for the microphone and intervene. So, Maria?
Well, I have to say that the patient was admitted at that moment. So what we did was number 3. We changed metformin to insulin, and we gave hydration with sodium chloride. So finally, we performed the coronary angiography. In the first image, we can see the LAT, which has a moderate lesion involving also the takeoff of the first diagonal branch, which is free of disease. And at the right side, we can see the left circumflex with a proximal lesion, which was considered severe, and also a chronic total occlusion of the distal vessel, which we can see here. We can see the distal vessel, which have collaterals coming from the first diagonal branch. And the last image is the right coronary artery with a proximal and very tight lesion, and also some other moderate lesions at the mid-segment, and also there's no arrow, but at the distal segment. So to summarize, we have 3 vessel disease involving proximal segments and with a complete chronic total occlusion of the distal left circ. And as I've said at the beginning, this patient also had carotid artery disease, which had been diagnosed with an ultrasound which showed a severe stenosis of the right internal carotid artery. And we completed this study with a brain MRI, so no ischemic lesions, and an MR angiogram, which showed also the same severe stenosis at the right ICA, and moderate stenosis at the left side. So to recapitulate, we have a 71-year-old male patient with type 2 diabetes, peripheral vascular disease, mild renal dysfunction, a severe right internal carotid artery stenosis, angina class 3, a positive aspect with a non-transmural scar, moderately reduced ejection fraction, and 3 vessel disease. And here comes the most difficult question. What should we do now? We could perform only PCI of the proximal right coronary artery, multivessel PCI, surgery, coronary surgery. We could do first carotid revascularization and then coronary surgery, or a combined surgery.
Did you calculate the syntax score on that patient?
The syntax score was intermediate, 26.5.
So the case is complicating. The decision is not so easy as the first questions. So who of you would opt for a single PCI of the right coronary artery? Multivessel angioplasty? A lot of cardiac interventionists here. Surgery? First carotid revascularization, then surgery, and all in the same procedure, combined procedure. So, diversity of opinions.
May change my mind. I would think I would perform an off-pump arterial grafting on this patient and do a combined carotid procedure as well.
A combined procedure with an off-pump coronary surgery.
Yeah.
It probably depends a lot of this decision of the local experience of the cardiac and vascular teams, I guess.
That's true, but we want to discuss the optimal treatment. Since he is a diabetic patient, he would do best with multiple arterial grafts long term, and PCI wouldn't work that well at the long term, and the right carotid is kind of significant. The other vessels do have a good collateralization, so I would think that the carotid endarterectomy is very easy to do at the same time.
Do you agree with this approach?
Well, the first thing I'd like to know is, Fred, you put your hand up immediately for multivessel PCI, and I'm sitting next to a surgeon from the Syntax trial. Perhaps you could just tell us what your fear of doing just regular bypass surgery or even off-pump in a patient with asymptomatic carotid artery disease and known peripheral arterial disease.
I mean, the problem here is that you can't take veins for this peripheral arterial disease. You have to, which I think is, on the other hand, very important for a patient who has diabetes, that we use the radial artery and we use both IMAs, and this will be the best option for the patient. And to avoid a stroke, in that case, it should be a non-touch operation of the aorta. And to do the carotid is a very simple add-on.
Because this is obviously a very high-risk patient with a number of issues that have already been summarized here. I guess without the carotid disease, he would be a freedom patient. But even if we're talking about multivessel PCI, bypass surgery, I agree, if he's going to have surgery, he really should be having multiple arterial grafts if we can. But we also need to involve the patient in this discussion, and so what their preference is. Obviously, the lesions we saw angiographically, at least in the LAD and that proximal circumflex in the right, are certainly treatable with PCI.
So would you ask for FFR, what's coming later in some of these lesions, because especially the LAD lesion was not so tight?
Probably this is a critical issue because the LAD lesion didn't appear to be very, very critical. Did you perform?
No, so it always hurts me to send a patient to the surgeon, but because I think this is a doable PCI. However, thinking the whole context, diabetic with CKD, and not only for freedom, recent analysis from the Stitch study, although this is a different patient, this patient has a low EF, 38%, I believe. There's a 10-year mortality benefit. So if I have a good surgeon that can guarantee arterial grafts, then I would prefer surgery. However, if I have a surgeon that will either perform an incomplete revascularization or do not use complete arterial grafts, then I would consider PCI. for this specific reason.
But then you have to guarantee a interventional cardiologist who can do that without any risk, you know. I mean, you take a risk on either side.
Of course. But these are you know, multivessel PCI. We do them pretty routine. My biggest concern in this case was actually the mismatch in that that ostial circ with the more distal segment where there was a dilatation. I think all other lesions were very doable in my opinion. But I think these are the classical cases. However, I do believe that you need to stop after the procedure, discuss with the patient, and discuss the various treatment options. But this is the type of patient, I did not say it before, for this specific reason, I would have not pre-treated with clopidogrel. I mean, this patient had ridden triple vessel disease all over the place.
Mm-hmm.
Yeah.
Especially if not sent to surgery.
Could I just follow up the FFR question? And Maria, can you just remind us, was there anterior ischemia on the stress test?
Was mild anterior and moderate infralateral.
Yeah, so it was mainly infralateral is what I saw there. But remember, you know, he stopped exercise after 3.5 minutes, so this is a very high-risk stress test. And I agree with you. I think the LAD lesion looks a little borderline. On the other hand, if we sent this patient for bypass surgery, none of our surgeons would leave the LAD ungrafted. And you know, we don't have enough data where FFR guides, you know, the surgeon there. But I mean, I don't think there's any FFRs needed of the right and the circumflex lesion. I mean, we've got the ischemia demonstrated there. I guess if there's any question and you're going to do multivessel PCI, I think we probably should be doing FFR of that LAD, you know, if that question comes up. But if you already have ischemia, I don't think you need to do that. But Fred, I mean, if you were going to take this patient to surgery, would you want to know what the FFR was of that LAD? Or would that, our surgeons also don't really want to take patients for bypass surgery unless they're going to graft the LAD. Yeah. So maybe that would be the time to know whether or not it was significant.
I think that's a very important question. In this case, there was also a diagonal of the stenosis. And it's true, if the FFR shows there is no significant stenosis, there will be some competitive flow, and some of the grafts, especially the radial artery, will close off. So in this case, I would do a sequential grafting, taking the diagonal and the LAD to have two target vessels on for the anterior wall, and that should work quite well in this case.
Okay, so we have to move on.
The question in general is if what we found in the frame study, if what is true, obviously true for PCI, does not mean necessarily it's true for surgery. You know, if we can do the sequential grafting and sometimes low gradient vessels stay open.
Thank you. Can you continue, Maria?
Well, in our hospital, we don't normally do combined surgery. So, based on the guidelines, if we decide to perform an staged surgery, we should target first the most symptomatic disease. So in our case was the coronary disease. So with the multidisciplinary team involving cardiologists and both cardiac surgeon and vascular surgery, obviously with patient's approval, we decided to revascularize only the proximal lesion on the right coronary artery. So finally, we implanted a drug-eluting stent at the proximal RCA, and the patient was discharged with 12 months of dual antiplatelet therapy. Here we can see the final result. And some months later, before the carotid surgery, we performed another aspect, which was positive, with angina and ST depression. And here in the images, we can see again the non-transmural inferolateral necrosis and only mild inferolateral ischemia. So we will repeat the coronary angiography, and we saw no restenosis, and the rest of the lesions remain the same. And finally, vascular surgeons implanted a stent with no complications. And after more than 4 years of follow-up, the patient has mild angina, no events, and the ejection fraction remains the same.
So this case illustrates perhaps how difficult it is to translate evidence-based medicine to a particular complex patient with a lot of items that need to be considered. And regarding the issue of the FFR, it is this case is from a few years ago. I think that FFR was not routinely performed in this hospital to select the indication for coronary angioplasty in intermediate lesions. For sure, if evaluated now, it would be mandatory. Do you have any comment?
Yeah, actually I have a question for Maria. So the follow-up stress test, well, actually before the stress test, I mean, did his angina improve?
Yeah.
Did it disappear? And then did the follow-up stress test, did that demonstrate that he had better exercise capacity?
Yeah, he like 7 or 8 meds. And the ST depression appeared at the last of the exercise.
I mean, the only other comment to make is that at our institution, and I'm not a cardiac surgeon, but I'm fairly certain that we do not do combined procedures, carotid and coronaries, for many, many years. I remember this was always a big debate, maybe 20 years or so ago, but we really stopped doing that, particularly in someone who's asymptomatic. We certainly might have considered stenting the carotid. I suspect that many of my colleagues would probably have taken the patient for surgery and grafted everything. Whether we actually now have, I think sort of a newer generation of surgeons in the United States who are actually, I think, using many more arterial grafts than we've used in the past. I think we are definitely behind a number of places in Europe with respect to that. But if I send a patient for bypass surgery, and particularly if they're diabetic, and particularly if they're sort of middle-aged, in their 50s, 60s, maybe 70, I'm just insisting on multiple arterial grafts.
Yeah, and I agree with you. So my thing, and congratulations on the presentation, and things went well in this case, but I do believe in 2016, I understand this was 4 years ago, we always need to strive for complete revascularization, because even though this patient's symptoms improved, he was still symptomatic. He had class 1 to 2 angina, and we do know that residual syntax score is a predictor of outcomes. And so this is the reason why that I think that when you have a patient like this, I prefer sooner than later trying to achieve complete revascularization, because this patient can have the coronary disease that progresses over time. Revascularization can be more difficult. He's younger. 4 years ago, he's 71, and with time he may develop more comorbidities. But this is my take.
Would you have performed combined revascularization in the same procedure?
No, because I think you need to, because the patient was asymptomatic from his carotid disease, I would have had the patient recover from his bypass surgery and then consider a carotid endarterectomy.
I mean, this is also a political question. There are only few surgeons who are still trained doing carotids and bypass surgery or open heart surgery. Very often, the heart surgeons do heart surgery and ask a vascular surgeon to come into the procedure, and this is kind of conflicting the situation. In such situations, I would also think about the two-stage procedure and. In experienced hands, it has been proven that if there is a tight stenosis, one can do with a very low risk simultaneously.
I have a question. In the discussion in the multidisciplinary team, you used your score. The patient was demanded by the surgeons to know the risks for surgery, because the anatomy was very good for bypass surgery. And as Dominic is explaining, here is we can see a symptomatic guided strategy. When you fix the lesion that is mostly producing the angina, and then you leave the other coronary tree to the outcome of the patient. But the problem is that the event, maybe it's a new MI or sudden death, I don't know. The other side, you can follow up more prognosis, guided therapy, and then CABG is more maybe complete. But as well, what we were discussing, we're interventionalists, we could assess a lady with FFR and to try to open the circ. Viability is not definitely ruled out here, no? And I think the strategy is good because for the patient work, but taking the case as a general case that you can have every week is not an unusual case. It's a symptomatic guided approach. You solve the problem now, no angina the next month, but you still have lesions in mid-RCA, you have lesions in LAD, you have the occluded circ. At the same time, the patient is moderate risk for surgery, not definitely high, no, it's mid, right, risk. I think EURO score 2 is maybe going to be around 4 or 5.
It's low. It was 2 points.
Then it's still debatable, no, the case. I can imagine this case in my hospital with strong discussion between interventionalists, surgeons, because it's difficult, really. I don't know very clearly if it's better to do this or to do a more complete approach from the beginning.
Yeah, but the thing is that now he has no angina, almost no angina, and at the second spec he had no ischemia, no anterior.
This is retrospective. You are watching the follow-up of the patient now and you say, I was okay, the patient did well. The problem is that when you see this patient up front, you have to think that in the studies and freedom, in symptoms, and to know that the diabetic patients have a lot of plaques getting around in the coronary tree. And if you only fix the 90% lesion, the patient is going to have a lot of events related with other plaques. You can see it in prospect, you can see this in freedom, or in symptoms, that these patients have a lot of events in 5-10 years follow-up that are related with other plaques, and not the plaques that you see in the angio, in the first angio.
Yeah, but
Can I make just a very short comment. So the importance of complete revascularization is definitely worth discussing. We don't have the time to do that, but remember that stenting is just like spot welding. You're just fixing that one spot, and that's where the advantage is with bypass surgery, obviously, because you take care of the whole vessel. It doesn't really matter if it occludes proximally. And then you did talk about the syntax score. Of course, in a diabetic patient, at least from Freedom, the outcome was independent of the syntax score. It didn't really matter. You could have intermediate scores. They still did better with surgery.
But if you took the diabetic patients in the syntax score, in the syntax trial, they showed a better outcome by surgery. Both the insulin-dependent and non-insulin dependent.
Yeah, I think we're agreeing.
Thank you very much, Maria. We have to change to the second case.
Good afternoon. First of all, I would like to thank you for the invitation to participate in the symposium. Our clinical case is about a 39-year-old woman with a medical history of arterial hypertension, hypothyroidism, under treatment with alpha-methyl-dopa and levothyroxine. She hadn't any toxic habits, and she was on the 7th month of breastfeeding after the birth of her second son. She was admitted to the emergency department with a sudden onset of anginal chest pain. It was typical, retrosternal, oppressive, radiating to the neck and jaw, with vegetative symptoms that started at rest. On physical examination, the high levels of blood pressure is the only noteworthy finding. No jugular venous distension, without murmurs or crackles, no edema, and the peripheral pulse is well preserved. The electrocardiogram showed an ST7 elevation on the inferior leads. So, while waiting for the coronary angiography, which medical treatment would you have started? Single antiplatelet therapy or dual antiplatelet therapy with nitroglycerin, with beta blockers, or other combination?
So, who would vote for number 1? Number 2? Number 3, quite common. Number 4, other. So between number 3 and number 3.
I continue? Yes. We started, while we were waiting for the coronary angiography, single antiplatelet therapy with aspirin and intravenous nitroglycerin. An emergent coronary angiography was then performed, and it showed the involvement of the distal circumflex artery and the start of the intermediate branch, which suggested spontaneous coronary dissection with TIMI flow 3. We can see an abrupt change of caliber on the distal circumflex artery and a critical stenosis on the start of the intermediate branch, with the other arteries healthy. It was verified with OCT, where we can see the intramural hematoma. So, looking at the results of the coronary angiography, what therapeutic attitude would you have started? Conservative approach, percutaneous revascularization, or surgical revascularization?
So in the audience, who would perform medical treatment for this patient with intramural hematoma of percutaneous intervention and surgery? So medical therapy wins.
Yes.
Some comment from the
panel? So this is fascinating, because if you showed this case in any other audience in the world, I can guarantee that less than probably 20% of people would even think about spontaneous coronary artery dissection. It's just that there's been major contributions from this country in that field, so I'm just amazed. I've never seen this sort of response. This, for you, was the easy question, but for those of you who maybe weren't brave enough to put up your hand, the important thing is just to be able to recognize this. And still, at this age, although we're going to hear that she has spontaneous coronary artery dissection, still probably the commonest cause of acute MI is still atherosclerotic. This obviously, in this younger woman's, SCAD is obviously more common, but it's, anyway, it was just really a comment, just observing here, because when we talk about these cases in the United States, we have to educate people to even think about this. And I can tell you that a lot of audiences that we presented such cases, they went straight to a stent in that ramus branch. They may have actually not even seen that other abnormality you pointed out in the distal circumflex. They missed that. So the most important thing is recognition, but it's already a well-educated audience.
Well, one of your questions made the option of treatment with nitroglycerin or beta blockers. What was the response of arterial pressure to nitroglycerin?
The blood pressure decreased with the nitroglycerin. Well, according to the angiographic findings and a secondary vessel with TIMI flow 3 and the clinical stability and the low intensity pain, we chose a conservative approach. She was admitted into the cardiac intensive care unit. She was hemodynamically stable and with low intensity pain, 2 out of 10. We started performing dual antiplatelet therapy with aspirin and clopidogrel, and we started intravenous perfusion of beta blocker with esmolol.
I would like at this point to know the opinion of the panelists regarding the antithrombotic therapy in a patient with acute dissection.
We were just talking about this last week in relation to the data that we've looked at. I think, to be fair, we don't have any trials to tell us what we should be doing, but this is a very different mechanism to a typical ACS. And I think one of the analogies might be like an intramural hematoma in the aorta, for example. We would never give such a patient antiplatelet therapy, and we certainly wouldn't give them heparin. So I know that this is done a lot using either single or dual antiplatelet therapy, but I really question whether that is of any benefit and potentially harmful.
But that lesion is a little bit far away from the left main. is any connected or any connection to the heart?
No, I'm just saying that an analogy when we talk about intramural hematomas in the aorta, we would never anticoagulate, but no, this looks like this is isolated to the coronary arteries, no question here, but I still question, because of the underlying mechanism, which we still don't fully understand. I'm not sure if there is a role for dual antiplatelet therapy or even single antiplatelet therapy. And we actually were just talking last week about potentially starting a randomized trial, to address this question.
I agree with Malcolm. I mean, there's no data whatsoever. It's a different pathophysiology, and you're always concerned actually about creating harm because there's a hematoma. Anecdotally, at our center, it depends on the operator. One common rule, however, that we would never use one of the newer agents like prasugrel or ticagrelor in a patient with dissection. We actually see a lot at our center because my geographical region, we have a very large African American community, and we see dissections, spontaneous dissections all the time, and typically mid-distal LADs, and it varies between operators whether or not to add or not clopidogrel. They all get aspirin, and it varies from operator to operator whether or not to add clopidogrel. Typically, if it's a more proximal lesion, it will be added versus a more distal, but there's no science.
I continue. The echocardiogram showed normal biventricular function and the absence of any valve disease. However, after 2 hours, the chest pain appeared again, associated with ACG change which suggested diffuse ischemia. She evolved in a few minutes into a cardiogenic shock and cardiac arrest with electrical storm. She required advanced CPR techniques for approximately 20 minutes. She was intubated, and after the spontaneous circulation recovery, she needed inotropic and vasoactive drugs and repeated cardioversions because of ventricular tachycardia. Given the situation of hemodynamic instability, mechanical support was then performed with a ECMO implantation. We used a peripheral veno-arterial ECMO with a percutaneous femoral cannulation. We used a 19 French cannula on the right femoral artery, 23 French cannula on the right femoral vein, and a 6 French cannula on the superficial femoral artery for the distal perfusion. It was technically impossible to put the intra-aortic balloon pump because of the femoral access. A new coronary angiography was then performed, and it showed the proximal progression of the dissection towards the left main artery, but keeping TIMI flow free. The echocardiographic controls revealed a worsening of the ventricular function with a left ventricular ejection fraction around 20% with diffuse hypokinesis. In this moment, the patient was in a situation of hemodynamic and electrical stability supported by ECMO, and the ECG had normalized. So after these events, I asked you the same question again. What therapeutic attitude would you have taken? Conservative approach, percutaneous revascularization, or surgical revascularization?
Before that point, I would like to ask Susanna whether she would recommend any special co-treatments for this particular patient in this condition.
So I think you've done exactly what we would have done with respect to supporting the circulation. So peripheral VA ECMO is easy. You can even do it under the conditions of ECPR. I mean, it was 2 hours from when that very alarming ECG happened to when that woman arrested, and you wonder whether something earlier before you had cardiac arrest might have been helpful, because she's had 20 minutes of CPR and low flows, which isn't ideal. And whatever you do with your VA ECMO, you're now going to have to evaluate whether, if you're hoping that this myocardium is going to recover, whether you've appropriately offloaded the heart, and that can be sometimes very difficult, to assess. You need to look very carefully at your hemodynamics and make sure that you're not making the rest of, or any of the rest of the myocardium ischemic, because it's now alarmingly global looking, although the right ventricle is still looking pretty good. And then you're going to have to think very carefully about your level of anticoagulation that you're going to require, which is going to be aggressive if you're on VA for any length of time.
Okay, thank you. So for this patient that was initially treated conservatively, but in whom the dissection has progressed to the left main, what would be the more correct treatment for the audience? Number 1, number 2, number 3, surgery? A lot of no comments. Would you like to intervene?
Yeah, I think it's time to intervene. The ECMO by itself is not unloading the left ventricle because the left ventricle is failing. We do have a left main dissection plus the circumflexion, and I think the left ventricle is non-perfused, and to get the patient out of that situation, we have either do a PCI to the left main and to the circumflex branches, and may add on, even though Holger Thiele said a intra-aortic balloon wouldn't work. I think in such cases it's quite helpful because it will reduce the afterload and allow the patient being on ECMO to eject. I couldn't see exactly how the circumflex looked like. Maybe a good echo or the TEE would help to decide how distracted that is. But in any case, the patient needs a urgent revascularization, and since she is on ECMO, one could safely transport her to the OR and take care of these situations.
So I would agree. I think that while the initial conservative approach, I think, is what we'd all agree upon, she has certainly now declared herself as failing that. On the other hand, I think one of the critical things early on was getting control of that blood pressure, and whether or not that has contributed to this, I don't know, and I don't know how quickly the blood pressure came down, but I think this is one of those hypertensive emergencies. It's interesting, she did have TIMI3 flow there, and when we have such patients like this, who have failed, and particularly if it involves the left main, excuse me, we generally would lean more towards surgical revascularization, but although we've had some debates about that among my colleagues, but I think we also know that the results of PCI in these patients can be really dismal, and I would be worried that we would just propagate this whole dissection. We'd go from TIMI3 flow to zero, and it may be that, being provocative here, and emotionally this would not be an easy task, is with time this might settle down, and when she comes off ECMO, without any revascularization. But I think that would take an incredibly courageous team to treat her conservatively. So we would go with surgical revascularization here.
Can I just say that when you've put your patient on ECMO and you're feeling comfortable because the numbers all look nice, I think it's very easy to be misled into thinking that you've treated the problem. And ECMO is not a treatment. And if you want this woman to have a heart that's going to work again, you have to be 100% certain that she's got good coronary perfusion. And it can be quite difficult to, it's easy to convince yourself you've done the right thing, and almost definitely you haven't done enough in this woman looking at her echocardiogram. So ECMO is not a treatment, I guess, we always have to remind ourselves. It just supports the heart whilst whatever is reversible can be reversed.
So if one would decide to go on with ECMO and with watchful waiting, one has to put another line into the left ventricle to unload the left ventricle, that it is no longer that extended, and I would also put an intra-aortic balloon pump on top and see what happens. But anyway, that's second best option. The best option is to go for surgery right away.
For sure, and while you're waiting, I mean, certainly it's routine for us if we put a patient on peripheral VA ECMO, we'll measure the end diastolic pressure in the cath lab, and if it's elevated, we will, if we can, put a balloon pump in and measure the change in diastolic pressure. And you can see very dramatic changes instantly. I know that there are differences in opinion across Europe and people do different things, but you're there, it's quick, it's easy, and if you drop the left ventricular end diastolic pressure dramatically, it can be a very useful thing to do. The other options that you have in the cath lab, you can do an atrial septostomy, which is relatively easy to do, very much favoured by the paediatric cardiac surgeons, not so much by our adult cardiac surgical colleagues, but as a passive way of offloading the left ventricle, it can be helpful.
Yes, and I just want to echo what Malcolm just said. You know, we would have sent this patient to surgery. My biggest concern with PCI, when it involves the left main, and you believe one of the major branches is involved, is the dissection, once it involves the left main in some shape or form. If you're putting a stent, like in this case, from the left main into the circ, I mean, the chances of the dissection propagating into the LAD is extremely, extremely high. And we see that in these cases, as well in spontaneous catheter dissections. And so it's interesting, we had an identical patient to this 3 weeks ago, young girl, 32 years old, almost identical in conservative management. After 3 days, went into cardiogenic shock, CPR, we sent the patient to surgery, and she did well. The question is, which I would have for the surgeon, is there are different schools of thoughts on how you want to bypass this patient. Are you going to use an arterial graft, or are you going to use venous? Because some surgeons may say, well, you don't have flow-limiting stenosis, your lima is going to become immediately atretic, and might as well put a venous graft, which will stay open a little bit longer. Now, we don't have any randomized trials, obviously. It's more personal experience, so I'd like to ask the surgical perspective, how would you graft this patient?
I mean, this depends on the surgeon. I think the question is surviving that situation first, and if the circumflex artery and the LAD are dissected down into the peripheral parts where you want to perform an anastomosis with an IMA may be extremely difficult. So that may be easier to perform with a vein graft first, because you can go for longer anastomosis and take deeper bites. So it really depends on the patient, how big is the IMA, how quickly can you get the IMA down. If the LAD is not dissected and you just have a normal LAD, I would for sure put an LAD IMA graft, but for the circumflex, I would think it would not really matter. You could go for a vein graft right away, and if necessary, even close the proximal part of the LAD to stop the inflow into the dissection.
So what did you do, Marta?
We thought that the better option is to go to surgical revascularization, so we called the surgeons to go to the operating room urgently, but the surgery was programmed on the next morning. So she was admitted again into the cardiac intensive care unit, and we began a standard treatment with the ECMO support. However, after a few hours, a new episode of hemodynamic instability, together with ECG alteration, led us to a third coronary angiography. And now it was confirmed the proximal progression of the dissection with flow compromise of the left main artery, and now it also affected the left anterior descending artery and the first diagonal branch. Due to the situation of instability, with the patient absolutely dependent on the ECMO support, we thought that she had to undergo revascularization as soon as possible. So, a complete percutaneous vascularization was applied with drug-eluting stents. They were implanted in left main left anterior descending artery, median and proximal LAD, proximal circumflex, and the start of intermedius branch, with a good angiographic and hemodynamic result, as we can see in the video. It was confirmed with OCT, where we can see the stent is compressing the intramural hematoma, and we can see the correct sealing of the distal edge, an example. After revascularization, the patient remained stable under the ECMO support, and we even started the weaning, but the third day after the ECMO implant, she presented again a new episode of hemodynamic instability, but now it was conditioned by a pericardial effusion with cardiac tamponade. She hadn't any significant pleural effusion at the same moment, so we performed a surgical drainage of 500 milliliters serous fluid with a pericardial window, followed by a remarkable improvement. We chose the surgical approach because of the possibility that it was a secondary complication of the ECMO cannulation. However, the patient still showed severe biventricular dysfunction without aortic valve opening continuously, and she required mechanical support without a successful weaning. Given the possibility that the cardiogenic shock became irreversible, the patient was transferred to a heart transplant center, and there the mechanical support was replaced by a longer-lasting support system. A left ventricular assist device was implanted and a central veno-arterial ECMO on the right side. The improvement in her hemodynamic condition and the biventricular contractility made it possible to reduce the mechanical support, and the weaning was achieved after 11 days. It was followed by a process of respiratory and physical rehabilitation, and during that time she needed a surgical drainage of pericardial effusion in 2 other occasions, and the treatment for candidemia caused by Candida parasylopsis. The study of the spontaneous dissection included a thoracoabdominal CT scan, which showed a small aneurysm on the left renal artery, and also a carotid arteriogram was performed, and it revealed the classical appearance of a string of beads on the right carotid artery, which appears in fibromuscular dysplasia. The patient was discharged approximately 1.5 months after her admission. With this treatment we can see there. She had a Q wave on the inferior leads, and at the end she had normal biventricular function. In conclusion, this is a typical case of fibromuscular dysplasia as a cause of spontaneous coronary dissection in a young lactating woman, but also exceptional because of the need of mechanical circulatory support. The spontaneous coronary dissection is responsible for a significant percentage of cases of acute coronary syndrome in young women, and the fibromuscular dysplasia is the underlying cause in many cases. About treatment, there is a little evidence and sometimes controversial. Therefore, it is a real challenge for the heart team. And finally, the veno-arterial ECMO is a great device as bridge to decision in catastrophic cases.
So thank you
very
Marta.
much.
This is really an exceptional case.
Thank you.
Fortunately, very rare. I don't know whether there is any short comment from the panelists regarding the final events and the final outcome of this patient. We are out of time, so very short, please.
Well, I think it proves Susanna's point. As I said, this patient had declared herself, and she needed urgent revascularization. And I guess we probably would not have waited till next day. We would have done it immediately. I think also just the other point that you also made about the left ventricle. And this was a left ventricle that wasn't vented, so maybe things would. But at the end, I mean, she did okay. But these are challenging cases, and fortunately, these catastrophic outcomes are very, very rare. But I think once they've had a recurrence of their event, they really need rapid revascularization.
Okay, so if there are no more comments, thank you very much for the 2 presenters and from the panelists for an excellent participation.
Gracias.